Hi friends, welcome to my channel Vasu Medical Diary. Today we are going to see second chapter of NABH Standards 5th edition. Second chapter is having 20 standards and 142 objective elements. So the chapter 2 is care of patient, COP. In that first standard, uniform care to patient is provided in all settings of the organization and is guided by written guidance and the applicable laws and regulations. Uniform care, what they means is from the registration until the discharge, the patient should be cared in a uniform way. The organization has a uniform process for identification of patient and at a minimum use of two identifiers. For example, you have to identify the patient with full name, date of birth, and if you are using Aadhaar card, it should be same from the moment of registration until discharge process. Care shall be provided in consonance with the applicable laws and regulations. Make sure you are adhering with the laws of local, state, district, and Indian regulations and laws. The organization adapts evidence-based clinical practice guidelines and or clinical protocols to guide uniform patient care, which means obviously all the hospitals will be having medical quality. So the quality will do the root cause analysis of all the events, incidents and the sentinel events. So all these sentinel events or incidents or any incident which happens will be analyzed by the quality department. So they have to do some corrective action and preventive action. These preventive action must be based on evidence-based practice. Clinical care pathways are developed, consistently followed all across the setting of the care and reviewed periodically. So if you are creating some clinical care pathways based on any standardized sectors, so it should be consistently followed from the ER until the discharge process wherever the patient is getting transferred. Care delivery is uniform for a given clinical condition when similar care is provided in more than one setting. For example, you are treating a patient with a back pain. It will be same in ER as well as in the wards as well as if anywhere in the hospital if they are going. The multidisciplinary care will be same everywhere. And the multidisciplinary and multi-speciality care where appropriate is planned based on best clinical practices, clinical practice guidelines and delivered in a uniform manner across the organization. So you will have a dedicated person to deliver the care. It should be uniform from the moment of registration till the discharge. And telemedicine facility is provided by safely and securely based on the written guidance. If you have a telemedicine facility, it should have some policies and it should be implemented uniformly all over the hospital. So we are done with first standard. Second standard is emergency services are provided in accordance with the written guidance, applicable laws and regulations. So there shall be an identified area in the organization which is easily accessible to receive and manage emergency patient with adequate and appropriate resource. So in your hospital, the emergency department should be easily accessible. Without any hurdle, the patient should get into the department. So prevention of patient overcrowding should be planned and crowd management measures are implemented. There should be a planned policy for crowd management and the management of patient. And emergency care is provided in consonance with statutory requirements and in accordance with the written guidelines. So always you will have some statutory requirements like ambulance license, BLS card of all the drivers and the staff nurses, ACLS licensing with the American Heart Association and the guidelines, what all the guidelines are given by the statutory requirements, everything should be followed in emergency department. The organization manages medico-legal cases in accordance with the statutory requirements. In case of MLC, you should follow the local rules. And initiation of appropriate care is guided by a system of triage. So if any patient coming into the emergency, If you following CETAs, like you have 5 triaging system, just based on your written policy, you have to follow your patient's triage system and quickly manage them under which category they are going. Whether if they are blue, they'll go under resuscitation. If it is red, it is emergency. If it is yellow, urgency. And if it is green, it will be a less urgent patient, and if it is white, it will be a non-urgent patient. So maybe if it is, this is Canadian CETAs. Same like that, whichever your organization is following, based on that, you have to categorize the patient to quickly prioritize them. And patients waiting in the emergency are reassessed as appropriate for the changes in the status. Maybe if your emergency, you are giving some intervention for the patient complaint, then you have to reassess the patient appropriately when they are in the emergency itself, and then you have to check for their changes in the status and follow the treatment as per their current status. Admission, discharge to home, or transfer to another organization is documented. In case of discharge to home or transfer to another organization, a discharge transfer note shall be given to the patient. If at all the patient is leaving your organization, you have to give a discharge note to the patient. Everybody is having the right to get their discharge summary. The organization shall implement a quality assurance program. There should be a quality assurance program in the organization. The organization has system in place for the management of patients found dead on arrival and patients who die within a few minutes of arrival. So there should be a plan, a written policy should be there for death on arrival cases. How are you going to manage? Are you going to give a death certificate for them, or how are you managing those certification issues? And then everything should be planned in coordinates with the committee people, and then have a policy for that. Third standard, ambulance service ensures safe patient transportation with the appropriate care. The organization has access to ambulance service commensurate with the scope of services provided by them. So if you have a list of scope of service, so based on them, for example, you have a cardiac service, then you should have a ambulance round the clock to receive MI patients. Same like that, based on your for example, you have a neonatal services, means if any preterm babies are there, you should be able to shift them immediately for the tertiary care. All those things should be kept in mind. And there are adequate access and space for the ambulance, for the parking, and the ambulance is fit for the purpose and is appropriately equipped for the emergency. And the ambulance is operated by trained personnel. The ambulance is checked daily for the equipments and as well as for the medicines, and a mechanism in place to ensure that emergency medications are available in the ambulance. The ambulance has a proper communication system during emergency or during the patient transfer. They should have a proper communication system. And the emergency department identifies opportunities to initiate the treatment at the earliest when the patient is in transit to the organization. So if you are planning to transfer them to any other organization, you should identify and treat them at the earliest and stabilize them before sending them. Standard 4. The organization plans and implements mechanism for the care of patients during community emergencies, epidemics, and other disaster. So we should have the plan for disaster management. The organization identifies potential community emergencies, epidemics, and other disasters. The organization manages community emergencies, epidemics, and other disasters as per a documented plan. Provision is made for availability of medical supplies, equipment, and materials during such emergencies. There should be a disaster management cupboard separately, and there should be a mock drill. The plan is tested at least twice a year with the mock drills. COP 5. Cardiopulmonary resuscitation services are provided uniformly across the organization. Resuscitation services are available to the patients at all time. During cardiopulmonary resuscitation, assigned roles and responsibilities are compiled with, and equipment and medications for use during cardiopulmonary resuscitations are available in various areas of the organization. The events during cardiopulmonary resuscitations are recorded. A multidisciplinary committee does a post-event analysis of cardiopulmonary resuscitations. Usually it is a code blue committee or the CPR committee who will do a analysis about the intervention of these things. And corrective and preventive measures are taken based on the post-event analysis. COP6. Nursing care is provided to the patient in the organization in consonance with clinical protocols. Nursing care is provided to the patient in accordance with the written guidelines, and the organization develops and implements nursing clinical practice guidelines reflecting current standards of the practice. Assignment of patient care is done as per the current good clinical nursing practice guidelines, and the organization implements acuity based staffing to improve the patient outcomes, which means the nurse patient ratio should be based on the acute level, means severity level of the patient. If it is ICU, 1:1 for the ventilator, and non-ventilator 1:2, and other patient maybe 1:5 or 1:6. And nursing care is aligned and integrated with overall patient care, and the care provided by nurses is documented in the patient record. Nurses are provided with appropriate and adequate equipment for providing safe and efficient nursing care. Nurses are empowered to make the patient care decisions within their scope of practice. COP7. Clinical procedures are performed in a safe manner, which means the procedures are performed based on the clinical needs of the patient. Only if it is relevant, we are going to do clinical procedure. And the performance of various clinical procedure is based on written guidelines, and the qualified personnel order, plan, perform, and assist in performing the procedure. Care is taken to prevent adverse events like a wrong patient, wrong procedure, and wrong site. So we are implementing this with surgical safety checklist. Informed consent is taken by the personnel performing the procedure wherever it is applicable. The procedure is done adhering to the standard precautions, and the patients are appropriately monitored during and after the procedure. Procedures are documented accurately in the patient's record. 8th standard. Transfusion services are provided as per the scope of service of the organization safely. Scope of transfusion services is commensurate with the services provided by the organization, and the transfusion of blood and blood components is done safely. Blood and blood components are used rationally. So there will be a policy for rational use of blood. Only blood components are allowed to transfused, and it is encouraged. Whole blood is nowadays we are avoiding transfusion of whole blood to avoid pulmonary embolism and fluid overload. And informed consent is obtained for transfusion of blood and blood components. Informed consent also includes patient and family education about the donation. Blood and blood components are always available for use in emergency situations within a defined time frame. So in case of any emergency within a defined time frame, you should be able to get blood for the transfusion. Post-transfusion form is collected, reactions if any identified, and there are analyzed for preventive and corrective actions. The organization shall implement a quality assurance program. COP9. The organization provides care in intensive care and high dependency units in a systematic manner. So care of patient in intensive care unit and high dependency units is provided based on written guidelines. So ICU and HDU will have a written policy to take care of the patient. The defined admission and discharge criteria for intensive care and high dependency units are implemented. So it is not only defining, it should be implemented throughout the hospital. Adequate staff and equipment should be available in ICU and HDU. And the organization endeavors to upgrade its physical infrastructure to meet national and international guidelines, define procedures for the situation of bed shortage and for followed. In case of bed shortage, what are you going to do with the ICU and HDU patients? For that, there should be some policies. Infection control practices are followed, and the organization shall implement a quality assurance program in ICU and HDU. The organization has a mechanism to counsel the patient and family periodically. During the change of patient condition, the hospital people should have a policy to update to the friends and family about the patient condition. COP10. Organization provides safe obstetric care. So, obstetric services are organized and provided safely. The organization identifies and provides care to the high risk obstetric cases and, where needed, refers them to another appropriate center. Person caring for high risk obstetric cases are competent. They should have separate competent checklists. They have to complete all those things before handling high risk patient. Antenatal services are provided. Obstetric patients assessment also includes maternal and nutrition assessment. Appropriate perinatal and postnatal monitoring is performed. The organization caring for high risk obstetric cases has the facilities to take care of the neonates of such cases. COP11. Organization provides safe pediatric services. Pediatric services are organized and provided safely, and neonatal care is in consonance with the national international guidelines. Those who care for children have age-specific competency. Provisions are made for special care of children, and pediatric assessment include growth, development, and immunization assessment. The organization has measures in place to prevent child neonatal abduction and abuse. The child family members are educated about nutrition, immunization, and safe parenting. COP12. Procedural sedation is provided in a consistent and safe manner. Procedural sedation is administered in a consistent manner. Informed consent for administration of procedural sedation is obtained. Competent and trained persons administer sedation. The person monitoring sedation is different from the person performing the procedure. For example, the surgeon cannot give sedation. There should be separate anesthetist to give sedation and to monitor the patient. Whoever is doing a procedure will be busy in procedure itself. So there should be a independent person who will do that. Intra-procedure monitoring includes at a minimum the heart rate, cardiac rhythm, respiratory rate, blood pressure, oxygen saturation and level of sedation should be monitored during the procedure. Patients are monitored after sedation and the same is documented. Usually we do Aldred scoring after post-operative patients, and based on the Aldred score only we will shift them to the ward. This is just a guidelines. It depends on the hospital to hospital basis. It may change. Criteria are used to determine the appropriateness of discharge from the observation to the recovery area. Equipment and workforce are available to manage patients who have gone into a deeper level of sedations than initially intended. So you are planning sedation, but the patient is in deep sedation, you are not able to wake up from that. You should have an additional plan and guidelines for that. So COP3, anesthesia services are provided in a consistent and safe manner. Likewise, same like a sedation, for anesthesia also it should be provided in a consistent and safe manner. Anesthesia services are provided in a consistent manner, and the pre-anesthesia assessment results in the formulation of an anesthesia plan, which is documented. We usually do PAC, pre-anesthesia checkup before surgery. A pre-induction assessment is performed and documented, which is PAC, and the anesthesiologist obtains informed consent for administration of anesthesia. During anesthesia, monitoring includes regular recording of temperature, heart rate, cardiac rhythm, respiratory rate, blood pressure, oxygen saturation, and end-tidal carbon dioxide. Patient's post-anesthesia status is monitored and documented. The anesthesiologist applies defined criteria to transfer the patient from the recovery area. The type of anesthesia and the anesthesia medications used are documented in the patient record. Procedures shall comply with the infection control guidelines to prevent cross-infection between patients. Intraoperative adverse anesthesia events are recorded and monitored. COP14. Surgical services are provided in a consistent and safe manner. Surgical services are provided in a consistent and safe manner, and the surgical patients have an preoperative assessment, a documented preoperative diagnosis, and a preoperative instructions are provided before surgery. Informed consent is obtained by a surgeon before the procedure. It is very mandatory that a surgeon should explain and get a signature, not the sisters. Care is taken to prevent adverse event like the wrong site, wrong patient, and wrong surgery. So like site marking and all will be there for you bilateral surgeries. In case if the organ is bilateral, we have to go for site marking and there is a specific criteria for site marking we have to follow. An operative note is documented before transport of a patient. Yes, doctors cannot write the surgery note once the patient is out to the ward. They have to write inside the OT itself. Post-operative care is guided by a documented plan, and patient, personnel, and material flow conform to infection control practices. Appropriate facilities, equipment, instruments, and supplies are available in the operating theatre, and the organization shall implement a quality assurance program. The quality assurance program includes surveillance of the operation theatre environment. Like we will be doing a culture test to find out is there any bacteria available inside the theatre. We will be doing routine check for that. The organ transplant program is carried out safely. What they are telling in this, the organ transplant program shall be in a consonance with the legal requirements and shall be conducted ethically. Care of transplant patient is guided by clinical practice guidelines, and the organization ensures education and counseling of recipient and donor through trained quality counselors before organ transplantation. The organization shall take measures to create awareness regarding organ donation. COP6. The organization identifies and manages patients who are at higher risk of morbidity and mortality. The organization identifies and manages vulnerable patients. So vulnerables we should have identify. We should, in our assessment form itself we should know who all are vulnerable patient, and we may identify them with some different ID band or something, like who is pregnant, mentally ill, above 60, below 5, and like patient is after surgery, in a sedation. All these things are vulnerable. All these patients are vulnerable. So depends on the institutional policy. We have to identify them, and the organization provides a safe and secure environment for these patients. The organization identifies and manages patients who are at risk for fall, and the organization identifies and manages who are at risk of developing worsening of pressure ulcers. The organization identifies and manages patients who are at risk of developing deep vein thrombosis, and the organization identifies and manages patients who in need of restraints. COP17. Pain management for patient is done in a consistent manner. Patients in pain are effectively managed. Patient is screened for pain. Patient with pain undergo detailed assessment and periodic reassessment. Pain alleviation measures or medications are initiated and titrated according to the patient's need and response. COP18. Rehabilitation services are provided to the patients in a safe, collaborative and consistent manner. Scope of the rehabilitation services at a minimum is commensurate to the services provided by the organization. Rehabilitation services are provided in a consistent manner, and care providers collaboratively plan rehabilitation services. There are adequate space and equipment to provide rehabilitation, and care is guided by functional assessment and periodic reassessment, which are done and documented. Care is provided adhering to the infection control and safety practices. Care pathways are developed, implemented, and reviewed periodically. COP19. Nutritional therapy is provided to the patients consistently and collaboratively. Once the patient is admitted to the organization, they have to be screened for nutritional risk. Nutritional assessment is done for the patient found at risk during the nutritional screening. The therapeutic diet is planned and provided collaboratively, and patient receive food according to the written order for the diet. When family provides food, they are educated about the patient's diet limitations. COP20. End-of-life care is provided in a compassionate and considerate manner. End-of-life care is provided in a consistent manner in the organization. A multi-professional approach is used to provide end-of-life care. End-of-life care is in consonance with the legal requirements, and end-of-life care also addresses the identification of unique needs of such patients and family. Symptomatic treatment is provided when where appropriate measures are taken for the alleviation of pain. So that's all with care of patient, chapter number 2. Thank you, friends. We will see in chapter number 3, MOM, Management of Medications. Thank you.